we can. Okay, perfect. So hi everyone, welcome. Thank you for joining us tonight. I'm very excited about this presentation. I actually got a little preview of it before and it's really interesting. I forget how complicated it is to do the easiest thing you could do, which is sleep. So I'm very excited that we have Dr. Aruna Rao at Johns Hopkins here with us tonight. She's a neurologist. And what I usually do, just so everyone knows how this is going to go, Dr. Rao is going to give a brief presentation, and then afterwards, we're going to take questions that were sent in before. And then after, I might be having network connection difficulties, so I apologize if there's an issue. But what I like to start with is have the speaker sort of introduce themselves, explain why they're interested in Chiari and syringomyelia related disorders. So I'm going to just ask you that, and then you can go right into your presentation, and I'm actually going to disappear for a bit, maybe figure out my own network issues.
Okay.
Whenever you're ready.
Okay. So hello, everyone, and thank you so much for inviting me to do this presentation. The reason I'm interested in Chiari malformation and syringomyelia is because I work specifically in the cerebrospinal fluid disorder center, where this is primarily these any condition related to cerebrospinal fluid is what we see and what I treat. I work mostly on the inpatient side where we do intracerebral pressure monitoring, and I'm also trained in sleep disorders. And over the course of these many years that I've been doing this, I've been just fascinated by the connection between the brain and sleep and cerebrospinal fluid and sleep, and I'm definitely passionate about sleep, and I'm very I'm fortunate that I work in a place where I get to work with such wonderful people like Dr. Luciano and Dr. Wong, where we're constantly thinking about and finding new things in these conditions. So I mean, basically, I'm passionate about it all. That's why I do this. So can I start with a presentation?
Absolutely.
Okay, great. All right, so so let's start with, I wish we could have done this, in person, because I really, the audience interaction is just so so important to me. But nevertheless, I'm so glad you're all here today. And can't advance my slides. Oh, there you go. Okay, so I have no disclosures. The goals of this talk are to be able to understand the pathophysiology of sleep, understand how neurologic changes in Chiari malformation influence sleep, and syringomyelia, I should add, learn about the common sleep disorders, and in general, and in particular with Chiari malformation and syringomyelia, because the interaction is just very interesting and important, and to also discuss basic approaches to diagnoses and management of sleep disorders in general, and also as it pertains to syringomyelia and Chiari malformation. So what is sleep? I've been asked before, is sleep coma? Is sleep anesthesia? And the truth is no, sleep is not, right? Sleep is a very active process in your brain, or driven by your brain, I should say. And it is a natural state where your motor activity is reduced, and you have reduced response to stimulation. And most people have a stereotypic posture, right? When we sleep on our side or back or tummy. And it's very different from coma and anesthesia because it is self-regulating. You fall asleep when your brain is ready, you wake up when you're ready, and it is easily reversible because any number of things can easily wake you up. Very, very different from coma or anesthesia, where you require something, either treatment for coma or anesthesia reversal agents. Now, it is a very active period. Now, I will go into this a little bit more in detail, but there's lots of processes happening during sleep and a lot of restorative processes as well, which is why it is so relevant to neurologic conditions in general. So to start out with, let's look at some of the neuroanatomical features. Now, the circadian clock, or the master clock, if you will, is a tiny little nucleus in a part of your brain called the hypothalamus. And that is the major timekeeper of everything. What time you go to bed, what time you feel sleepy, what time you your brain wakes up. If you can imagine this as the master clock, and tiny little clocks all over your gut, your liver, all your cells have a little clock. And timekeeping is a very, very important function of the suprachiasmatic nucleus and your body functions. Now, way back when, in the caveman days, right, they just had light and dark cycles to go by, and so your circadian clock very easily adjusted to the light and dark cycles. Now, for us, we have a lot of artificial light and a lot of artificial stimulation that we really makes our circadian clock work a little bit harder. Now, what happens when, I'm going to start with the nighttime. So when darkness hits your eye, it hits the retinohypothalamic tract. So the hypothalamus is what is stimulated where the suprachiasmatic nucleus lies. Melatonin is released. It's an intricate balance of just neurochemicals and neurons being activated and being suppressed. Melatonin is secreted, and then you go and it works on the sleep promoting chemicals, and you go to sleep. When the converse happens, when light hits your retina, it speaks to your retinohypothalamic tract, again, suprachiasmatic nucleus, shuts down all the sleep promoting chemicals, and you're awake. All of these processes, or most of these processes, are in the brainstem and in the upper cervical region, which, as you know, is very relevant to Chiari malformation and syringomyelia. What other processes that control sleep? So the two main processes that control sleep are the circadian process, which is driven by the suprachiasmatic nucleus, and the homeostatic process, which is a marker of how sleep deprived you are. So the more sleep deprived you are, the deeper sleep you will have. So as soon as you wake up, this is 6 a.m. here, someone wakes up at 6 a.m., adenosine is a chemical that starts to get secreted, and it increases and increases and increases, and it gets to a critical mass, at which point the sleep component takes over. The circadian process is very much driven by the suprachiasmatic nucleus, and it's time-stamped. So the circadian clock typically governs your REM, or rapid eye movement sleep, and it timestamps it. So a normal REM period could be 11, 1, 3, 5. Later in the night, the longer the REM periods, and the more of them you do have. But someone who has, say, a shifted circadian rhythm, not this person 6 a.m. to 6 p.m. or 6 p.m. to 6 a.m. Rhythm, you could have your first REM period occur at 2 a.m. or 4 a.m. Those are what we call the night owls. Or if your REM period occurs at 6 p.m. or 7 p.m., you would be an early bird. So, these processes have to work in sync in order to get your full component of sleep. Now, the whole circadian cycle is about 24 hours in humans. And throughout the process, day and night, your circadian rhythm is keeping time, as you will see in later slides. Okay, so the two types of sleep are REM sleep and non-REM sleep, and it is misunderstanding that REM sleep is very important, because people often will come to clinic and say, oh, I didn't get enough REM sleep, and my Fitbit said I didn't get enough REM sleep. And to be honest, your non-REM sleep is equally important. So in non-REM sleep, what happens is that your brain is quiet, but the rest of your body, your blood pressure, heart rate, your muscles are all working normally. Physical restoration happens the most when you're in non-REM sleep. It is driven again by the homeostatic pressures we just saw, and it is like being on an elevator. I will often describe. So as soon as you close your eyes, you have slow waves. So you go into N1 sleep first, N2, and then slow wave sleep, which is the most deep sleep that you get. In REM sleep, it is driven by the circadian process. You have an active brain. So your brain is active, but your muscles have to be almost completely paralyzed. Otherwise, everyone will be acting out their dreams. So it's your body's natural mechanism to quiet down the muscles. Now, it's very important for mental restoration, memory. The hippocampus consolidates all the learning that you do during the day. And it's in regards to what we're talking about today, cerebrospinal fluid drainage occurs mostly during REM sleep. So cerebrospinal fluid, we'll talk about in a little bit, has to get cleaned out. It's a continuous process of going into the brain, getting washed out of the brain, and this primarily takes place during REM sleep. Isn't that exciting? I was so excited when I read that in that research. Now, people often ask me, how much time should I sleep? Here is a chart telling you what babies, so from 1 week of age until 16 years of age, because after 16 years of age, the amount of sleep that you need is about the same until, and there's no age limit. So when babies are born, they have equal amounts of day and night sleep, but this diminishes as they grow older. And by 5 years of age, so just about the time that nap time ends in school, they have mostly nighttime sleep, and this just continues for the rest of their life. So the quantity of sleep that you need is, according to the nurses research study, 5 hours 45 minutes is the lower limit, and the highest is above 9, because anyone getting more sleep above 9 just indicates that there's something more. Their body is fighting harder to get restorative sleep. Typically, cardiovascular disease is a cause for the long sleepers. Certainly, it could be medications and other things as well, but ideally 7 hours of sleep is what we shoot for. Okay. The chemicals in your brain are the neurotransmitters. As the word signifies, they are transmitting messages from your hypothalamus to the wake promoting centers or to the sleep promoting centers. You may recognize some of these: serotonergic neurons, so serotonin, important for anxiety, mood; noradrenergic neurons, which are or adrenaline, which is important for the wakefulness and fight or flight reactions; cholinergic neurons, dopaminergic neurons are very specific. And all of these, especially except the histaminic neurons, which are a little bit more frontal, these are all located in the back of your brain here. And as you can see, can be quite affected depending on the level of tonsillar descent or spinal cord involvement. Cerebrospinal fluid, again, is formed in the ventricles, goes all the way down to the spinal cord, comes all the way back up, and gets absorbed back into the brain. And this process keeps going on during the day, during the night. But like I said, a robust amount of it is happening during REM sleep. Now, as you can see, any compression here by the cerebellar tonsils occludes this area, so it impedes that flow of cerebrospinal fluid. There could be it's just plumbing right in the end, so there is a backup of fluid here. The back pressure then goes down, is transmitted down, either making the cerebellar tonsillar herniation worse or increasing syringomyelia. Cerebrospinal fluid pressures, as I will show you later, do increase during sleep, and particularly if you do have sleep disordered breathing or other disorders that are affecting your sleep. It also increases when you're flexing your neck or extending your neck, really pointing to the pillow or the way your bed is positioned, and the position of your neck during sleep. And certainly the presence or absence of a syrinx is very important for cerebrospinal fluid dynamics. In addition, the skull and the cervical spine offer protection, but also can be compressive forces. So as you can see here, with the cerebellum hanging lower, you get the cervical vertebrae 1 and 2 compressing, and that compression can cause some damage, particularly to the breathing centers located in the upper cervical cord, or the back pressure from the tonsils affecting the brainstem and the sleep related centers. So in the specifics to Chiari malformation in terms of sleep disorders is basically the alterations in the sleep-related brainstem structures. So not only does it affect the brainstem structures that we just talked about, the locus coeruleus, the dorsal raphe, the serotonergic pathways, or the histaminergic pathways or dopaminergic pathways, the pons. It also affects the lower cranial nerves. The cardiorespiratory centers are in the medulla. The cervical spinal cord sends impulses, gets impulses in and away to the respiratory muscles. The lower cranial nerves also get impulses from the pharynx and the upper airway. The cervical nerves get impulses and send impulses to the intercostal or the rib cage, the chest muscles. And then, as I said before, the cerebrospinal fluid drainage, which also happens during sleep, are quite relevant. So really, it's important to pay, I think, or to keep in mind the anatomic changes that are happening in Chiari malformation and syringomyelia, and as it relates to sleep disorders and sleep mechanics, honestly. So common sleep problems. So when people come to the clinic, often these are the complaints. I cannot fall or stay asleep, which is called insomnia. Weird things happen during sleep, parasomnias. I fall asleep during the day, daytime sleepiness. I stop breathing at night, apneas. My legs bother me, periodic leg movements. Now, these are the only conditions that have been studied in Chiari malformation and syringomyelia. But there are a myriad of other sleep disorders. So let's start with insomnia. Okay, so what is insomnia? Difficulty initiating sleep, difficulty maintaining sleep, unrefreshing sleep, or waking up too early, right? Does this relate to anyone? Usually, for me, when I'm stressed or I have something pending the next day, I could be this way. So what happens though? It's all, again, going back to those neurotransmitters. You are wired, right? Look at this clock sitting right here at the bedside table. This is the worst thing for insomnia. Never look at that clock when you have insomnia. The minute you look at the clock, you realize you only have 2 more hours to sleep. All the stress chemicals are up, stress hormones. Those same stress hormones or chemicals or neurotransmitters are also responsible for wake promoting. So you're awake, look at the clock again, and the cycle repeats until it's time to get out of bed. So what happens though when these neurotransmitters are active is that you have increased heart rate, increased temperature, of course you're more alert. And then what happens over time, if you have insomnia for long term, people then start to associate their bed with not being able to sleep. So then it becomes a conditioned state. Oh, you look at your bed, immediately you get anxious because you now associate your bed with insomnia. So the most important causes are mood disorders and anxiety disorders, and as you will see later, particularly anxiety disorders and Chiari malformation, poor sleep hygiene, which we'll talk about, sleep apnea as a cause of insomnia, other leg movements and medication certainly are very, very important to rule out as causes of insomnia. Sometimes in terms of medications, it might just be changing the timing of the medication to morning instead of evening could make all the difference. So daytime complaints, naturally, if you haven't slept at night, you're fatigued, you're sluggish, you're sleepy. Somatic symptoms get worse when you haven't slept well, worsening headaches particularly. Then you stress out about not being able to sleep during the day. You can get more depressed, more anxious, definitely poor concentration and impaired performance, as many studies have shown. In Chiari malformation, as I mentioned before, anxiety is associated with insomnia in patients with Chiari malformation, particularly due to the compression of the serotonergic serotonergic and the noradrenergic neurons in the brainstem. And in addition, sleep-related breathing, so sleep apnea, is also a cause of insomnia and Chiari malformation. So you can have sleep fragmentation, which leads to sleep deprivation, which causes increased anxiety, which then causes the insomnia because of the anxiety. Post-operatively in Chiari malformation, it is important to note that studies have shown improvement not only in the Chiari symptoms, but also the insomnia. And patients who have had decompression surgeries or other corrective surgeries have had better response to anxiety treatment after the surgery. So they're very much interconnected, and treating just one part of the problem could result in incomplete treatment. So let's talk about sleep hygiene. So just looking at this picture here, I mean, does this room look conducive to sleep? And we could play a game and try to figure out where would you sleep in this room. It's really hard to tell. I don't know. The floor maybe right here. But anyway, so sleep hygiene is the first thing we would do in terms of intervening when someone comes in for sleep evaluation. We will look at we get nosy about your sleep. Where do you sleep? What time do you sleep? What time do you wake up? What kind of pillow do you have? What kind of bed do you have? So really the important things are to maintain a consistent bedtime and rise time, but also don't forget your circadian rhythm. Figure out what your circadian clock is saying. It's not a good idea to lie in bed waiting for sleep to come. It is better for you to go to bed when sleepy. Make sure your bed and the pillow are comfortable, especially in Chiari and syringomyelia. The neck support could be important. You might need a horseshoe pillow. You might need to sleep on your side, or different positional therapies for sleep. Neck flexion, neck extension can all affect the symptoms and your ability to sleep. Because if you have any pain or discomfort, you're probably not going to sleep well. The room typically cool temperatures are better. Dark room, eye mask, earplugs, anything that you need to minimize light or noise. And pets are particular interests, quite disruptive to sleep. Cats more than dogs, I've found. So, I mean, and coming up with a behavioral program for pets is almost impossible. So it's better to train them early on, I would say, so that they're not disruptive to your sleep. I've had patients actually have insomnia because their dog snores. But regardless, cats are far more disruptive and temperamental when you try to put them out of the room. Technology, I don't need to tell you, the blue light from phones, iPads, television tricks your brain into thinking it's daytime. So typically we'll say turn them off at least 1 to 2 hours before bedtime, or use the blue light blocking apps. Your clock is the enemy of sleep. Only use it to wake you up in the morning. Avoid heavy evening meals, because again, it's a signal to your circadian clock that it's daytime, therefore is going to make your sleep very light. Typically we'll say 3 to 4 hours before bedtime should be your last meal, so that your brain gets ready to go into sleep mode as well. I say avoid alcohol, but really it's almost better to I mean, I can't say don't drink, but just know that the effects of alcohol are that you will have a very deep sleep early on, but it disrupts your sleep later on, and can also make sleep apnea worse, particularly central sleep apnea, which is quite significant in Chiari malformation. Minimize caffeine after midday, between 2 and 3 in the afternoon for a normal 11 p.m. bedtime, because it lasts 6 to 7 hours in your system. Avoid napping, again, because it affects that homeostatic drive, homeostatic pressure. You need that homeostatic pressure to fall asleep. So if you nap during the day, that homeostatic pressure has to start to build up again. And it may not build up till much later on the day, on the night that you've had a nap. It's all about those neurotransmitters, those chemicals, getting to a critical level before you could, all the sleep promoting areas of your brain are activated. Emotional problems can really affect your sleep. So it's really best to tackle them during the day. Often we'll recommend journaling, or it's about compartmentalizing. If you need to have a to-do list or a worry, if you have specific anxieties, best to journal them pick a time during the day and journal them so they are compartmentalized. And it sounds silly, but it is actually a very profound tool to help with your insomnia, and in maintenance insomnia particularly. Exercise regularly, but not close to bedtime, because again, all those endorphins, the wake promoting chemicals, neurotransmitters are elevated and could affect the quality of your sleep, if not your ability to fall asleep. Okay, so if you've tried sleep hygiene and that doesn't work, then we move on to behavioral treatments. As you can see, medications are always last on the list and have to have very specific indications. So behavioral treatments are cognitive behavioral therapy, not only for insomnia, but also specifically if there's anxiety or mood component to the insomnia, progressive muscle relaxation. And if any of you suffer from insomnia, I would urge you to check out these apps. Headspace, a Calm app, have a lot of bedtime specific programs. So mindfulness, meditation, deep breathing, bedtime stories. A lot of my patients like the Headspace app better than the Calm app, but certainly they're comparable tools. Medication wise, all the medications that we use for sleep, except melatonin, which I'll talk about separately, suppress your brainstem function. When you already have a vulnerable brainstem function, you want to be a little bit careful about these medications. And you'll see when I talk about sleep apnea why it is important. You're already starting with the baseline of suppressed breathing and suppressed responsiveness to breathing problems, that adding another suppressant is just going to compound the problem. A lot of times medications can lead to parasomnias, the nighttime behaviors, nighttime eating, nighttime driving, nighttime texting, and also 50% of these medications, the specific sleep medications, the benzodiazepine receptor agonist, stays in your system the next day, especially for women. So the next day, if you're sleepy, you're going to think you're sleepy because you didn't have enough sleep, and you might want to take more medication the next night, when the truth is that you may still have the after effects of the medications that you took the night before. And then you end up on just higher and higher dose and no restful sleep and a profound daytime sleepiness. Some antidepressants, if are used for depression or anxiety, can be used for sleep. So it's best to choose a medication that's doing double duty, instead of picking 2 or 3 medications for 3 different indications. Antihistamines are commonly found over the counter, okay for short term. All of these medications are okay for short term, not for long term use. There is a dependency, not so much physiologically, but psychologically. People may feel that, okay, I'm not going to be able to sleep if I don't take my Benadryl tonight. And so that leads to a psychological dependence. Melatonin I'd like to mention separately because it is not exactly a sleep medication. I know it is marketed as such, but it is a signal. It is a neurochemical. It is, by taking melatonin, you're tricking your brain into thinking it's bedtime. So, or to jumpstart the sleep process. So really, if you take melatonin, it's not the dose that's important. More than 9 milligrams is never helpful. Typically 3 or 6 milligrams should suffice. But you also want to take it 3 or 4 hours before you want to go to bed, because that's how long it takes from the start of melatonin release to when sleep occurs in natural, normal circumstances. So moving on to breathing. So breathing during sleep is particularly important because during the day, voluntary breathing mechanisms, you can stop, you can hold your breath, you can breathe faster, you can breathe slower. But during the night, I'm not going to say night because some people sleep during the day, but during sleep, you do rely on automatic mechanisms. And it's all about the neurons, it's all about those neurotransmitters and the muscle receptors, levels of carbon dioxide and oxygen in your body. So the neurons particularly, they control breathing in, breathing inspiration, expiration, the muscles, your sleep-wake system, as you've already seen before. And all the 3 groups of neurons that are particularly important are located in the brainstem, the pons and the lower brainstem. The Lower cranial nerves, 7, 9, 10th, and 11th, particularly 9th and 10th that are particularly affected in Chiari malformation, and the 12th. All the lower cranial nerves are important. And then you have a lot of receptors that are sensitive to oxygen levels and carbon dioxide levels in your bloodstream, and respond if there's a change. Sorry, oops. Sorry, guys. And then you have the mechanoreceptors, which are present in the muscles, not only in the upper airway, but also in your chest wall. Now, in REM sleep, of particular note is that the diaphragm is the only muscle that's functioning. And in general, there's decreased respiration in sleep overall. But having just one breathing muscle functioning is going to make that even more important to maintain. And as I mentioned before, in REM sleep, all other muscles are paralyzed. Just the one life-saving muscle, but the diaphragm is controlled by the upper cervical spine, so C3, 4, and 5. And if you have a syrinx in that area and expansion, it could affect diaphragmatic function as well. Okay, so what happens to when you lie down? Your palate falls back, your tongue falls back, and your airflow goes through your nose and down behind the palate and into your airway here. If this area narrows, you snore. If it completely closes, you stop breathing. But your brain is so sensitive to not having oxygen that it's going to wake you up so you could take a breath, either from a deep sleep to a light sleep or completely awake. Now, every time this happens, the pressure in your chest cavity goes up. It affects the blood flow to your heart, away from your heart. When you test patients' blood for inflammatory factors, all the inflammatory factors are increased. So your body's in a state of inflammation. Blood sugars can be affected. Liver metabolism can be affected. So it may the most important or the most obvious sign might be up here in the airway, but the consequences are far-reaching. And we'll see a little bit in a little bit how it affects the brain. So what happens during apnea is that your airway closes, you have a drop in oxygen. In obstructive apnea, your respiratory muscles, your effort, because the whole system is now put into opening up that airway, all the efforts. And so your thoracic, your chest muscles, your abdominal muscles are trying to push through that obstruction, and you still have some effort. Now, in central apnea, there is no effort, because in central apnea, it's either the brainstem that's affected, it's just not responding, or the heart, because the heart's pumping action is slowed or affected. So the oxygen level your low oxygen level doesn't reach the sensors for a longer time. So it just takes a longer time for the oxygen sensors to get the message and an even longer time for them to respond. And in mixed apneas, you have a mixture of both. So you have central, but your respiratory effort kicks in at the end. Normally during sleep, already your body is in a state of low metabolism. So decreased responsiveness to oxygen drops, decreased responsiveness to elevated carbon dioxide, increased resistance in your upper airway, lower lung volumes, lower respiratory rate, and as I said, your diaphragm is the only functioning muscle during REM sleep. So as you can see, you're already functioning at a lower metabolism, lower respiratory rate, and any other factors are just going to compound. And it's very important to look at some of those risk factors. So obesity is the #1 and most common. Now, this is not a factor in Chiari malformation and syringomyelia related sleep apnea, as I'll show you in some other slides. Lots of anatomical features, however, can be. So macroglossia is a larger tongue. Basically, if your anatomy doesn't match the content, so your oral cavity is too small for the content. So macroglossia, any craniofacial abnormalities, narrow chin, pushed back jaw, flattened face, upper face can affect your sleep apnea risk. Medication, certainly sedatives, narcotics for sure, and we see a lot of this in the hospital when we do intracerebral pressure monitoring. Opiates, alcohol, these are all risks for central sleep apnea. Cardiac disease, also mostly central sleep apnea, but also quite a lot of obstructive as well. Respiratory disease like COPD, again, it's that oxygenation that is affected. So their sensors are not going to get the message in time, so they cannot respond in time. And hormonal factors, particularly in women, postmenopausally. So what happens in Chiari malformation, though, in addition, is that we have other neurologic changes. So you have cranial nerve issues, you have diaphragmatic issues, you have autonomic dysfunction, and when you have a syrinx, you have the cervical cord, which again affects the diaphragm, the chest wall, and the responsiveness. In Chiari malformation, in patients with obstructive sleep apnea, they were found to have higher rates of macroglossia, larger neck size, and retrognathism, or your jaw that is pushed back, which I'll show you some pictures later. Central sleep apnea is also very common. So because of the respiratory centers in the brainstem, cranial and cervical nerves. And I saw one study where it said that patients who had vocal cord paralysis had a higher rates of central sleep apnea, which makes sense, but I did not see that replicated in other studies. And then you have a condition called central alveolar ventilation syndrome, where basically you're breathing, you're not able to breathe out. Your expiratory muscles are affected, therefore you have increased carbon dioxide retention. So a lot of times when you first stop breathing, your oxygen levels drop first, and then it picks up, and then your oxygen levels recover. But if your oxygen levels don't recover in time, then the carbon dioxide levels do start to rise, and that then drives the respiratory response from the brain. So, so you have both of these processes, but typically the oxygen recovers really quickly, so the carbon dioxide doesn't usually rise to high levels. But in central sleep apnea and central alveolar ventilation syndrome, that is a problem. And elevated carbon dioxide levels dilate the blood vessels in your brain, increase the blood flow, therefore increase intracerebral pressures, therefore can worsen Chiari or syrinx. Now, it's interesting that post-operatively after decompression surgeries, you can have sleep apnea develop. So it's very, very important to monitor patients very carefully post-operatively. In general, we do it for all post-op patients, especially if you've had abdominal surgery or brain surgery. But it's because of the swelling, the post-surgical swelling, that can cause some compression to that brainstem cervical cord area. So again, I found like one or two of the good studies that I found showed that they divided them by age, less than 18, 19 to 30, and above 31 years of age, and daytime sleepiness increased as the age increased. Snoring was highest in the 19 to 30 age group, but it's interesting to look at this body mass index. It's almost normal, 26.9. Okay, it's a little bit high, but it's certainly not as high as you would see in the general population, where we see body mass indexes of 35 to even 50. So in Chiari malformation, you don't need to have obesity as a major factor in sleep disordered breathing. It is primarily the respiratory centers in the brainstem and the cervical cord that are responsible. In this study, it looked at obstructive sleep apnea. This is all sleep apnea, this one here. And you can see, again, as they got older, the levels of sleep apnea got worse and obstructive sleep apnea. But the converse was true in central sleep apnea. So less than 18 years of age had higher levels of central sleep apnea. So what are the symptoms of sleep apnea? Actually, I have diagnosed many spouses with headaches based on their husband or wife snoring, because this poor woman here, sleep deprived and probably has headaches. But what you do often hear, and it's very important to have the bedtime partner report symptoms as well, because sometimes the person who has the symptoms may not be aware. So snoring, stop breathing, labored breathing is rare but can occur, gasping, choking, coughing, restless sleep, nighttime acid reflux, because as I said, the pressure in the chest cavity goes up, it opens up the lower esophagus sphincter and stomach acid goes up into your throat. Frequent urination, because there's a chemical called atrial natriuretic peptide that gets released. So if you go to the bathroom more at night than during the day, then you and if you have symptoms of sleep apnea, it's important to think about that. Nightmares as well, but typically sleep apnea nightmares, believe it or not, can be related to choking or underwater. Daytime, of course, all the effects of sleep deprivation, sleepiness, fatigue, behavioral problems, and learning problems, typically in children, and early morning headaches. Again, because increased CO2, carbon dioxide levels, blood vessels dilated blood vessels equal headaches. And typically the headaches are gone within 30 minutes or so. Other consequences, again, let's start with the heart. High blood pressure, abnormal heart rhythm. So if you have high blood pressure and we treat, and sleep apnea, and we treat the sleep apnea, blood pressure should come down. If you have cardiac arrhythmias, atrial fibrillation, for example, and sleep apnea, and you don't treat the sleep apnea, the atrial fibrillation is going to come back. And if you have heart disease, congestive heart failure, treating your sleep apnea is a very important part of the treatment. Metabolic effects, blood sugar levels are higher in sleep apnea, and generally lower immune function. The brain effects, as you already have probably surmised, memory, learning, inattention, and hyperactivity, very common in children who are not sleeping well. And typically in children, they have sleep apnea because they have tonsils or something anatomically that's affecting their sleep, tonsils or adenoids. Sometimes in older children, they can have obesity and other adult type of risk factors, and of course mood disorders. So sleep apnea makes depression and anxiety worse. Other effects on your heart, I should probably say blood or clotting, increased fibrinogen, increased platelet activation, and increased stress on your blood vessels. So therefore increased cardiac and stroke risk factors. This slide shows the mammillary bodies here, which are very, very important for memory. And this is in patients with sleep apnea, where you could see them really shrunken. As you already know, lots of errors happen. In fact, in the medical field, a lot of effort has been made to minimize sleep deprivation in residents and to help avoid errors. Sleep apnea increases intracerebral pressure, as I mentioned before. So basically, you have low oxygen levels, then leads to carbon dioxide level increase. Dilated blood vessels, increased cerebral blood flow. Right after the apneic events, there's actually a fall in blood flow, which then can cause increased stroke risks. But the more important factor for us in cerebrospinal fluid disorders is that the large blood pressure surges, increases cerebral perfusion, pressure, and the intracerebral pressure. And we see this all the time when we do intracerebral pressure monitoring. This is a snapshot of one of our continuous monitoring patients where we monitor them all night. And this is the EKG, here's the respiration. You can see them having apnea, an apneic event here, followed by an increase in intracerebral pressure, followed by the drop in oxygen. So really, the intracerebral pressure is much more of a robust response, has a much earlier response to the apneic event than the oxygen levels, the last thing to go down. So why is this relevant? So in Chiari malformation, in fact, I had a patient today that had this problem. Overnight, very high pressures and a Chiari malformation. Now, If you treat the Chiari malformation without treating the high pressures, there is a high risk of recurrence, because in this case, the high pressures are pushing, again, like I said, it is just dynamics, fluid and tissue dynamics in a confined space. More fluid, less space for the tissue. It has to go down somewhere, and so it gets pushed down. Now, am I saying that just treating the sleep apnea is going to make the Chiari malformation better? Or the intracerebral pressures better? Not necessarily. You might need medications as well, but treating the sleep apnea is a very important part to prevent recurrence. We've also had patients where they've had recurrent decompressions, but because of recurrences of Chiari malformation, and the important factor that was missed was significant sleep apnea affecting intracerebral pressures. So diagnosing sleep disorders. So like I said, when you come to the sleep clinic, we get nosy about your sleep, like your bedtime routine. Do you use an alarm? What time do you, how long does it take you to fall asleep? How many times do you wake up? What is your sleep like on the weekdays, weekends, vacation? And you'll be surprised how varied it is. Do you sleep better when you sleep at home? Do you sleep better when you sleep somewhere else? Nighttime symptoms, of course, like I said, snoring, gasping, choking, nighttime movements, sleep paralysis, hallucinations, dreams, and daytime symptoms of fatigue, sleepiness, headaches, and how often you take naps. And of course, medications, always, always. Ask medications that you take prescribed and non-prescribed, and recreational, I should add. Now, the things that we look for in exam are your uvula and palate. The position of your uvula and your palate are quite relevant. Here you can see that you could barely see the palate. You could see a little bit of the hard palate, and here you can't even see the hard palate. So this is already an at-risk oral cavity for sleep apnea. Tonsils are very important as well. I'll show you a picture of these kissing tonsils, as we call them. I mean, there's no airway here without removing these. So, of course, anatomical considerations. This poor little baby here has a very pushed back chin, or retrognathia, which can all affect the oral cavity and the respiratory muscles. Nasal obstruction, of course, nasal polyps or septal deviation or obstruction or foreign bodies stuck in the nose, which I have never seen personally, but I imagine pediatricians see that, can all affect your breathing and your sleep-related breathing. How do we diagnose sleep disorders, right? We will have people keep a sleep diary. And we will do an Epworth sleepiness scale to see how sleepy, and they have used this quite often in some of the Chiari studies, and it's a very common tool that we use. Do you never doze? Do you slightly doze? Do you have a moderate chance of dozing? Do you have a high chance of dozing? The most important things are driving. If you doze off while driving or in the middle of a conversation with someone, those are tip-offs that this person is very sleepy. Of course, the sleep study, which includes the EEG, a nasal cannula, leads around your eyes because of the rapid eye movements, and eye movements are very important in sleep. Chin electromyogram to look at the muscle movements. You also have EKG, a belt over your chest and abdomen to look at breathing movements, and you do have other electromyographic leads in your legs as well to look at leg movements and limb movements, all relevant to sleep. So if you do have sleep apnea, how do we treat it? So the primary treatment is positive airway pressure. And by this, I mean that you have a machine that sits on your bedside table and delivers warm, humidified air to essentially stent your airway open. So if your airway is collapsing at night, we need to keep it open. So if you think about a water hose without water going through it and with water going through it, how it expands, that's all CPAP does. People sometimes think it's oxygen, but it's not oxygen. It is just pressurized air. Typically, you want to use it for at least 7 hours, use it even for naps, but if you're getting enough sleep with the CPAP, you shouldn't require naps. Bi-level airway pressure delivers pressure both ways. So it helps with inspiration and also helps you with expiration. It's equal for sleep apnea, it's equal in terms of tolerability with CPAP. Adaptive servo ventilation is a new type of ventilation which also controls the tidal volume, the volumes in your lung, and it's typically used for central sleep apnea, but you want to avoid it in very, very bad heart failure. Weight loss is very important for sleep apnea, but not in Chiari and CSF, as I showed before, that body mass index is not a huge factor, no pun intended. And you can also use dental appliances for sleep, but typically only for mild sleep apnea. And there are a myriad of surgeries that ENT surgeons will perform, but only if you meet criteria. It's very important to choose a surgical candidate appropriately, and also the surgical technique, because surgery doesn't work for everybody. For bariatric surgery, weight is a big factor. Okay, so this is what I show this picture because even children can use CPAP and BiPAP, so there should be no reason why adults can't tolerate it. There are different kinds of masks. Typically, we recommend a nasal mask or nasal pillows. Now, there is a good algorithm for sleep apnea treatment in Chiari malformation. So if you have obstructive or mixed apneas, CPAP is usually the choice. If it is mild sleep apnea, you can use oral appliance or positional therapy. It's always the first line in one of these. And if the apneas disappear, great. If the apneas don't disappear, then you assess for posterior fossa decompression. In central apneas, generally, you go directly to the posterior fossa decompression. I would argue, though, that even in central apneas, it is worth giving CPAP a try. And it's certainly important to use in the post-operative period for all surgeries, or at least monitor very carefully. So this is what a dental appliance looks like. This is the tap device, which you adjust with this screw in the front of your oral cavity. It does change your bite. So during the daytime or in the morning, as soon as you wake up, you have to do some exercises to get your bite back in place. It does increase tongue muscle activity, reduces pharyngeal tissue folds, pulls the tongue forward, stabilizes the mandible and hyoid, but it's fit by a dental oral surgeon, and it's intermittently covered by insurance and only effective for mild sleep apnea. Like I said, the surgical treatment really depends on your anatomy. Not everyone will benefit from tonsillectomy, certainly. If it's obvious, take out the tonsils. I've had patients who've had their tonsils taken out and their sleep apnea still was severe. So in that case, it's the upper airway here. Now, in this case, you can see the palate is abutting the posterior pharyngeal wall, so cutting that out would help with improving the airflow here. However, not everybody has this. However, many people will have the surgery, have the uvula palate removed, and they still have sleep apnea because the problem is lower here in the airway. Nasal surgery certainly to remove obvious obstructions, and unfortunately tracheotomy for people who cannot breathe out effectively, and typically in the alveolar hyperventilation or the central sleep apnea where it's a problem of the chest wall not effectively pushing the carbon dioxide out, or the brainstem structures being damaged enough that the ventilatory response is compromised. Okay, let's talk about daytime sleepiness, which I'm sure you all know, if you don't get enough sleep at night, you're not going to be awake during the day. However, there are some more specific factors. Chronic insufficient sleep is the most obvious, but our job is to figure out why is this person getting insufficient or unrestful sleep. And then you have circadian rhythm disorders. Narcolepsy is a very specific disorder where you have deficiency of dopamine and you have of orexin, and you have an imbalance in the REM on and off and wake on and off. So that is a very specific condition that causes sleepiness. And then in Chiari malformation, there have been studies to show elevated rates of daytime sleepiness. So chronic insufficient sleep, as the years have gone by, we've gotten less and less sleep because we're busy, we have work to do, we have social pressures, we have medical disorders, and we have light all the time, television all the time, and also other sleep disorders which can affect your quality of sleep. Here's not an uncommon sight, and this will lead to daytime sleepiness. Irregular sleep-wake cycle. I mean, this is a sleep log of a patient. You can see here how disruptive the sleep is. 11 p.m. to midnight, then they sleep from 1 to 2 a.m. and then they've disrupted again until 4 a.m. And then, you know, again, they are sleep for an hour and disrupted again. So, you know, this could be someone on call actually, because this is somewhat what our nights on call look like. But yeah, again, it's going to lead to daytime sleepiness. Circadian rhythm, again, this is trying to match your circadian clock, what your circadian rhythm is setting for you with your social cycle or your social sleep rhythm. For example, my circadian rhythm is 9:30 to 5:30 a.m. If I had to wake up at 2 a.m. every morning or 3 a.m. as some people have to do to go to work, I'm going to be 2.5 hours sleep deprived every night. And that's going to lead to daytime sleepiness and errors at work, etc. So for some people, though, say they have to wake up at 7 a.m., but their brain doesn't shut down till 3 a.m. They're only getting 4 hours of sleep. So really, it's about figuring out what your circadian rhythm is saying. What time is my brain shutting down? What time is my brain waking me up? And then trying to match your sleep schedule and your social or work schedule to your circadian rhythm, because that's when you get the maximum benefit of your brain function. And if you cannot achieve this by yourself, then there are ways that we could do. We can move your circadian rhythm forward or backward using light or melatonin and other treatments. So in Chiari malformation specifically, daytime sleepiness is a big problem. I mean, 83%, 50%. These indicate the Epworth sleepiness score that we talked about. Again, this is only moderate sleepiness because really above 11 is severe sleepiness, but it's still very higher than the general population, 26 to 48%, and then 72%. Now, they also have looked at the sleep architectural changes in sleep studies, and there's a decrease in total sleep time. So the quality and efficiency of sleep is also affected. There's a decrease in the slow wave sleep and REM sleep, and there's sleep fragmentation, likely due to the neuroanatomical changes occurring in the brainstem, and of course, sleep apneas at higher rates in sleep and Chiari malformation as well. So again, as I mentioned, if you have daytime sleepiness, we will start with sleep hygiene, trying to move your circadian rhythm. If it's a circadian misalignment, try to figure out all the causes and treat those before we institute treatments for wakefulness. Really, we'll try with melatonin to help with your bedtime and light therapy, but light therapy is quite critical in terms of the timing, because if you time it too early, it could push your sleep cycle back further. So you really want to do it under the guidance of a sleep-trained physician or a practitioner. But again, these are common therapies that we use. And then as a last resort, if nothing else works, then we do use medications, stimulants and such. Okay, moving on to unusual movements in sleep. So parasomnias are anything that happens during sleep that shouldn't be happening during sleep, right? Walking, talking, people have sleep eating, sleep texting, sleep shopping, sleep driving. And so it's unpleasant, undesirable behavior, although eating, I don't know if it's undesirable necessarily, experiential phenomenon that can occur. So it could be dreams or nightmares, predominantly during sleep, and can occur during REM or non-REM. However, in Chiari malformation, the parasomnias observed were only REM sleep behavior disorder. I saw one case report of a non-REM parasomnia, but by and large, they're not common. And all the patients that were studied, or most of the patients that were studied with REM sleep behavior disorder, had craniovertebral malformation. So again, indicating the posterior brainstem and the upper cervical cord that are very important for REM sleep. Microtraumas caused by the bones compressing the neural structures. Again, if you recall the slide that I showed, and just the proximity to the brainstem and the upper cervical cord that can cause damage to the structures. Sleep disordered breathing can cause parasomnias, and post-operatively after decompression, studies found that both sleep apnea and the REM sleep behavior disorder improved. So again, pointing to the anatomical causation of these conditions. So what is REM sleep behavior disorder? Basically, in REM sleep, remember I told you that the brain is active, but your muscles are almost completely paralyzed except the diaphragm. In REM sleep behavior disorder, that muscle tone that is supposed to is not, the muscles are not paralyzed. So your brain is asleep, but your muscles are moving. So a lot of times people are acting out their dreams, or responding to some, typically it's dreams or nightmares, responding to some stimulus that is putting them in a half sleep, half wake state. And, what you want to do in terms of treatment is secure the environment, don't wake them up. A lot of times people fall out of bed, they bump their heads, they break their arms, their limbs. So a lot of times we will have people move everything out of their bedroom, like all furniture or anything that can hurt them. Have the mattress on the floor, if it, depending on how severe it is. I mean, it's unfortunate. Some people will tie themselves to their bed so they don't fall out. So bed rails, anything that you could do to protect them. Instituting a very regular sleep and wake schedule is important, because sleep deprivation can affect your REM sleep. Increase sleep time, avoiding antihistamines and stimulants is important. Relaxation techniques and mental imagery has been shown to help with this disorder. So this is, again, a sleep study showing here. These are the rapid eye movements that you see in REM sleep. This is the chin muscle EMG or electromyogram, and these are the leg muscle electromyograms that I showed you in the picture with the sleep study apparatus. And here you see the chin EMG, and the muscle leg EMG is active, and this is the hallmark of REM sleep behavior disorder, because this should be flat, just like this. Okay, the next condition is periodic leg movement disorder. It's higher percentage in Chiari malformation, 2% of the general population, 30% in people over 50 years of age, but 62% in Chiari malformation. And all patients that had leg movements in this group had a syrinx as well. So again, pointing to the cervical spinal cord and the effect on the motor movements of the legs and arms. So some of the causes, iron deficiency may play a role, kidney disease, pregnancy again through iron deficiency mainly, and some medications like antidepressant, particularly serotonergic antidepressants and antihistamines. So these are the things that we would want to rule out first before we attempt any treatment. What happens though is that you have periodic episodes of repetitive leg movements. So typically your leg bends at the toes, ankles, knees, hips, and arms. It's very stereotypical. And if it doesn't wake up the patient, we don't treat it. Because, or we try to find the causes. If it's iron deficiency, treat the causes. But if it doesn't disrupt sleep, or if it doesn't wake them up from sleep, we typically don't treat. One reason to potentially treat it is because sometimes when leg movements occur, there is a surge in the sympathetic system, so the noradrenergic system, and there are micro arousals in sleep that can be disruptive to sleep. So patients wake up and they don't feel rested even though they've had a full night of sleep, and in those cases we will treat it. We would never diagnose periodic leg movement disorder or restless leg syndrome just from a sleep study. Just because you have leg movements during a sleep study doesn't mean you have restless leg syndrome. Be wary of that diagnosis, because that is a completely different kettle of fish, and honestly much more complicated to treat. And it's best that you have a good evaluation and a thorough workup before embarking on that treatment. For periodic leg movements, I would say the most common use is and low-dose anticonvulsants, but you can use medications that increase dopamine, that are benzodiazepines. Sometimes melatonin is used, but typically it's a dopamine deficiency system. But low-dose anticonvulsants generally do the job. So this is what you would see on the sleep studies. The leg movements have these, the leg limb leads, the electromyographic leads have these periodic episodes of leg contraction or muscle contraction. But if it doesn't result in an arousal, like awakening or a disruption of sleep, typically we wouldn't treat that. Definitely not worth it. We don't treat it if the bed partner is complaining of it, or only the bed partner is complaining of it. So in summary, good quantity and quality of sleep is essential for all neurologic disorders. The anatomical abnormalities in Chiari malformation and syringomyelia pose unique risks for sleep disorders. What is required is a thorough evaluation take each patient as an individual and evaluate individual risk factors. And treatment must be tailored to address individual factors. As you can see, it's not one size fits all. And surgical treatment of Chiari malformation is an essential option for some sleep disorders. And that's all I have for you tonight, I should say.
Thank you, Dr. Rao. Okay, so we actually have a lot of really good questions that came in, so I want to get to them. But that was like a great, really detailed description of sleep disorders in Chiari, so that was awesome.
Thank you.
I'm going to start with, it's the last question to just come in, but it's a good lead into a Q&A session. So for REM sleep disorder, do you know if that presents with issues of absorption of CSF? I know you were talking about CSF drainage earlier, but is it common to see those things together?
Not necessarily. So REM sleep, I mean, it certainly could be a possibility, but in REM sleep behavior disorder, it is particularly in the pons area. I mean, it certainly could be, but I have not seen, well, and again, I should say that when I do intracerebral pressure monitoring, we're not looking at the limb leads and that, or the electromyographic leads. So we look at just the breathing. We have very limited leads. So I suppose if we did do, but we have done a lot of sleep studies in patients, and I have not seen REM sleep behavior disorder, particularly in these patients.
Okay.
So yeah, so I don't know. I mean, the patients that we pick up mostly are the sleep apnea patients that increase the intracerebral pressure, but not necessarily with the. That's a good question though, because there are different parts of the pons that are responsible for different disorders, and so it's possible that the more superficial regions that are affected in REM sleep behavior disorder are not necessarily the ones that are affected in sleep apnea.
It's interesting.
Because they're different. The brain controls, so the pons does have so there's the dorsal group, there's the ventral group, and different groups of neurons control different functions.
Okay.
I'm not 100% sure how to separate that, but I will look that up.
Perfect. Thank you. This was interesting too. Do you know anything about how common seizures are in sleep disorders, especially in relation to like craniocervical instability or brainstem compression, I guess, since we're talking about that stuff?
Yeah, so really good question. The sleep disorders don't cause the seizures. However, having a sleep disorder in addition to seizures is a risk factor. So whether it be sleep deprivation, or in fact, a lot of the times when we do EEGs for seizures, we do sleep deprived EEGs because you're trying to provoke the seizure, right? So having a sleep disorder, either sleep deprivation or sleep apnea, is going to make your seizure control less effective. Just like the anxiety, so treating the sleep disorder is going to make, so treating the sleep apnea, for example, or treating the Chiari decompression made the anxiety treatment better. Similarly, for treating sleep apnea or sleep deprivation makes the seizure treatment better.
Okay, that's interesting too. This was a good question. We get this a lot with some of the surgical, some of the symptoms that respond to surgery, and I wonder if this is true with sleep as well. But do issues with sleep seen in Chiari patients worsen over time? And I imagine that's if they don't undergo surgery. So if someone were to not have decompression, would those sleep issues get progressively worse?
More than likely, yes. And when I looked at that study, it was unclear whether those patients had had surgery or not. But as they age, and the older they got, the more sleep disorders they had. And the converse is that for the central sleep apnea. So I mean, it was really hard to say if, but generally, if you have a sleep disorder that's untreated because of an anatomical reason, and that anatomical reason has not corrected itself, I suspect in that younger group, the 18-year-old group that had higher central sleep apneas, as they aged, the anatomy somehow corrected for that portion, perhaps. That's the only explanation I could think of, because they didn't say in the study whether they had surgery or not. But in general, if you don't, for example, if you have sleep apnea and you haven't treated it for years and years, it is going to increase your Chiari, increase your risk of syringomyelia. And conversely, if the Chiari or syrinx is getting worse, it could worsen the sleep disorders as well.
So a question came in. I actually had written this down in a different way, so I'm going to ask. This is kind of like two questions, but the same. So needing more than a normal amount of nighttime sleep, is that associated with brainstem compression, decreased CSF flow? And I actually had that question in terms of patients just living with chronic pain. Do they need more of a specific type of sleep even? Because I know you said that the non-REM sleep is more about physical restoration. So I wonder if that's not normal, but I guess it would be abnormal, but is that something you see?
So normally when you have, you need both non-REM and REM sleep. Non-REM sleep is often, you always have more non-REM sleep than you have REM sleep. You only need about 20% of REM sleep. Most of your sleep is non-REM sleep anyway. So to answer the first part of your question, if someone is sleeping longer, so more than 9 hours, we definitely want to look at what is going on. Is it the medications? Is it just that the sleep is not restful enough, so they need more quantity of sleep? Or is there something else going on in the brainstem, that are their brainstem sleep centers being more suppressed because of whatever's going on anatomically? Or is it something cardiac or something else? So we really have to explore, when people are long sleepers, what is going on, whether it's the brain or the heart or the medications, or what external factors are causing this. Generally, less effective, less efficient sleep does increase the pain symptoms, and it decreases the pain threshold. Actually, it decreases the ability to tolerate pain. So yes, in general, I feel like it's less a marker of the long sleep. I think long sleep is a marker of you not having efficient sleep at night, and not having efficient sleep can increase your pain sensitivity, and also lower your pain threshold. Therefore, you are less tolerant to pain.
Yeah.
It also increases inflammation. So again, anything that is going to put your body in a state of inflammation is going to increase pain.
Hmm. So a question came in and sort of jumping off that. This was also sent in prior. Are you aware of any over-the-counter, either prescription or even alternative behavioral remedies that have worked for patients with Chiari or similar brainstem compression issues that have sleep difficulties? And what seems to help the most? Is it the behavioral stuff? Are there over-the-counter alternative methods?
So I think a lot of times in what I have seen is that it doesn't matter what the patient has, right? What someone has. It's really important to figure out what sleep disorder they have. Is it insomnia? Is it anxiety? I do see high rates of anxiety, which can certainly affect sleep. I personally have not. I did see, a few patients with a secondary care from the sleep apnea, but I would say it's very important, again, tailoring the treatment to the problem. I don't know. I think just other than anxiety and sleep-related anxiety and sleep hygiene, which again, I see in all patients, not just specific to Chiari. The things I would say that are specific to Chiari are discomfort from neck or neck position, pillows. Sometimes people can have irritation of the occipital nerves, which are in the back of the scalp. And so treating that. So anyone, especially who's had surgery or any manipulation to the scalp, those nerves can get irritated. And so when you lie, and they're right here on the scalp, very superficial, you lie down and you have compression of the nerves, that's going to cause pain. Neck issues or neck soreness, that can cause pain. So yeah, pain related issues and working on that, I find is more specific to Chiari, in addition to anxiety.
Hmm.
Other than that, any of the sleep disorders.
Yeah. Would you recommend maybe sleeping upright? Is that something that some people do?
I have not heard of that. What we do though, also, although Thomas Jefferson slept upright apparently, because I went to the house, and his bed was so small, and I'm like, how did he's a tall man, but he slept upright for some reason. Probably did not have good restful sleep though, is my guess.
Yeah, I would
Uh,
guess.
yeah, because eventually, right, when you're sleepy, you're going to fall over. So I would say, position wise, if you do want to elevate the head end of your bed, and we really have to think about how much of a Chiari is it? Is it, depending on the position and how bad the sleep are. For example, a patient that we just treated last night, we elevated the head end of the bed to 20 degrees. And you can achieve that by putting a wedge pillow under the mattress. You want to make sure though, if elevation of the head end flexes the neck, that could be bad or good, depending on what the malformation is. So yeah, elevating the head end of the bed is you can achieve that in many ways. You don't have to sleep upright. And honestly, sleeping upright might actually compound the problem, right? If it's low-lying cerebellar tonsils, so you want to discourage that. Sleeping on the side can be helpful. Sometimes using a horseshoe pillow can help with decreased compression to the brainstem area. So it really depends on what the anatomical issue is. And a lot of times when we do intracerebral pressure testing, for example, we'll bend the neck, like to the right, to the left, bend forward, bend backwards, and to try to figure out which position increases the pressure. And a lot of times bending forward definitely increases the pressure. And if there's sleep apnea, elevating the head end decreases the pressure
Hmm.
and the sleep apnea.
Yeah. So, as far as undergoing the posterior fossa decompression, the mechanism by which that improves the sleep disorders, is that that those neural structures are protected now, or
Yeah.
and is that something, I guess, that if you haven't had the decompression, is that long-term damage, or do you notice in the patients that they seem to get better over time?
I think that if they're, depending on the level of damage and the level of progressive damage. right? Because if the more you damage those neural, so it could be it's possible that there's static damage, right? There's one position, one level of Chiari, and and it stays the same forever. But it's a possibility that if the Chiari gets worse, then the damage is going to get worse. So it really depends on whether the problem is static or if it gets worse. Now, that being said, there could be other things that develop. There could be weight issues or hormonal issues or medications and other things that contribute to the problem. But if the problem is static and doesn't change anatomically, it shouldn't change the sleep structures any more than it already has.
And so when you have the corrective surgery, theoretically, as long as it was static, okay.
It should improve. At least all the studies have shown that sleep apnea improves, anxiety treatment improves, REM behavior disorder improves. So anything that's, again, directly caused by the Chiari should improve theoretically. And according to the studies, that was the case.
Yeah. One question that came in, what are the most concerning impacts of sleeplessness in patients with Chiari? Are there specific issues long term?
In general, the effects are the same, right? So sleep deprivation leads to all of these issues: memory issues, errors, accidents. In specific, it's going to increase pain and inflammation, which is the more specific issue for Chiari and syringomyelia. So it'll be much harder to get pain under control without getting the sleep under control.
This is actually a question that we had in the office because it was plaguing us. So people who do not have sleep apnea also snore, and I guess how do you know when snoring is pathology? How do you know when to go to the doctor, or just you wake up your friend and say, hey, can you be quiet? I'm trying to sleep.
Yes, exactly. So snoring is it's very interesting. So snoring is sort of a harbinger to impending sleep. So snoring. So when someone presents with snoring, say they gain some weight, then that becomes apnea or hypopnea or whatever, lower level apnea and then full blown apnea. But you can also have snoring just from engorged like sinuses or nasal passages. And it's essentially that your uvula is just vibrating. So a lot of what we look for is other symptoms, the symptoms that go along with the snoring. So snoring with witnessed apnea, the people actually notice that they stop breathing, or they are going to the bathroom at night, or they have not, or they have acid reflux at night. So it's really the company that the snoring keeps. Now, the easiest thing to do would be to sleep on the side if it's just the beginning stages of snoring. But if it is nasal congestion, I always check for nasal congestion and treat that, with nasal spray or saline or whatever. If someone is having to sleep on their side to prevent snoring, then it is sleep apnea is not far behind, unless they, so if any of the risk factors, they develop any of the risk factors, more than likely it'll become sleep apnea. But it's unusual to just have snoring without something causing it, either temporary or permanent. So I would say if someone just has snoring and possibly sleep apnea, no other nasal congestion or anything else that could be causing it, 5-pound weight loss, like even 5% of weight loss could help. So that's what I would suggest.
Okay. We actually had a couple of questions about headache. I was hoping that maybe you could take. So one person describes that they have these like strain type headaches. And it feels like pressure and pulling. It's not unbearable, but it can make it difficult to focus, kind of like the way that the sleep symptoms cause that. They were decompressed, but is it they're curious if the Chiari and or the syrinx, even after surgery, are causing these headaches. And what are the options to reduce those, like those strain related headaches? How can those get reduced?
So is it strain related headaches, meaning tension headaches, or is it strain in the neck, shoulder area? So depending on where the headache is located, the treatment or the cause could be different. So to answer the one part of the question, yes, certainly could be that the Chiari has recurred, right? Because that's not an uncommon thing. So whenever someone presents with headaches, we really want to look at, okay, what is caused, just like sleep disorders, what is causing this headache? Is it tension headache? Is it a migraine headache? It could be any type of headache. In fact, anything from the head and neck area feeds back into the headache center, right? So if it's post-operatively, definitely I'd be looking for musculoskeletal things anywhere in the neck area. So you could have, like I said, the occipital nerve irritation. Occipital neuralgia is very common in anyone who's had surgery, especially in the head and neck area. Trigger points are very common, especially from the muscle strain in the neck. So anything that irritates your neck, the cervical nerve roots, it causes the muscles to bunch of muscles and fibrous tissue to ball up into what we call trigger points. And essentially the treatment for the headache, and like I said, it all feeds back into the headache center, which is the same serotonergic, noradrenergic pathways that are involved in sleep. And so treating the trigger point, so figuring out, so what we do, really feeling the head and neck area and figuring out if it is it outside the head or is it inside. Is it tension or is it migraine or is it hypnic or numbula, whatever the headache is on the inside, or is it coming from the outside? Is going to be so important because it could be just as simple. Like this patient, for example, that we had with Chiari malformation has occipital neuralgia on the left and trigger point also on the left. And all the headaches were on the left. So we treated the occipital nerve by just a numbing, like a nerve block, just to get numbing for your teeth, and a trigger point injection to loosen up those muscle fibers, and the headache got better right away, right? So those are the patients that you don't want, you certainly don't want to subject someone to long-term medication use if the cause is something more superficial and treated more directly.
Yeah, that's a really good point. um, so what's the process of identifying whether or not someone suffers from more than one type of headache, and how does that affect treatment?
Oh, definitely affects treatment. I mean, headache history is quite specific, and and interestingly, headache disorders are so formulaic. It's hard to misdiagnose a headache because the diagnostic criteria are very specific. So, for example, if you have a throbbing headache lasting 4 to 72 hours with sensitivity to light and sound, nausea, and or vomiting, like it's very specific. It's so important to get the diagnostic category correctly because the treatments are quite specific as well. By and large, though, headaches associated with cerebrospinal fluid and migraine are related to blood vessels and blood vessels being dilated. So the treatments are a little bit more specific toward that, like reducing the blood flow, reducing the cerebrospinal fluid volume, or so sumatriptan or triptans, for example, that you use commonly for migraine, just constrict the blood vessels. That's how they treat the headache. However, if you have other types of headaches that are more locate, or their source origin is the hypothalamus, that same area where the circadian clock is, that's a completely different type of headache, the trigeminal autonomic cephalgias. They're short, they're very painful, they are associated with autonomic symptoms like tearing and congestion, and that treatment is very different. They can be seasonal, or wake you up in the middle of the night. So really, the headache history is very specific, and the treatments are very specific as well. So really, misdiagnosing a headache would be the worst thing to happen because the treatment, it's not, again, even in headache disorders, it's not one size fits all.
How do you recommend maybe someone figure out how to identify the headaches that they're having? Because I mean, obviously people can have more than one type of headache. Is it the log? I know you talked about the sleep log. Maybe is that how you have your patients track those as well?
Yeah, it does. It is, but I like people, it's more important to describe them clearly. So if you have 3 types of headache, trying to explaining specifically, okay, because the specific questions we're going to ask are, where's the headache? Can you point with one finger where it hurts? What makes it better? What makes it worse? What does it feel like? And any associated symptoms, right? Is it your vision? Is it your sound sensitivity? Is it nausea, vomiting? You have any chair? So being able to answer those specific some headache questions, I think the more specific you are. Now, I will say there's a high rate of so there's a unidirectional relationship between headaches and anxiety, bidirectional with mood and headaches. So it's very important to also assess for those. And the reason I tell people when they keep a headache calendar is not to get into the details, is because then the anxiety gets heightened, or the mood gets heightened. The headache diary is so helpful in terms of when it occurs. So for example, if we're trying to figure out, especially in relationship to menstrual cycles, for example, or I had a patient, for example, every other Tuesday he would have a headache, because on every other Wednesday, he had a committee meeting where he would have a stressful committee member. So you know what I mean? So it could be quite specific. So I told him, just get rid of that committee member or stop having those committee meetings. You know what I mean? So it could be like, if you only have headaches on Mondays, or you only have headaches on Sunday nights because you're going into work the next day. Like, so it's really, the headache calendar is more helpful. Of course, the headache history, like what kind of headache you're having, but the headache calendar is more helpful to figure out the triggers.
Yeah, that's a really good point. I didn't even think of that. The headache calendar can actually cause a headache. um, so a question came in: to what degree does pregabalin help with headache? And does it apply to only certain types? What's the generally acceptable therapeutic dose?
Yeah, generally, I would say I don't use pregabalin for headaches because it's a very, very good headache medicine, but I use gabapentin more. If you are going to, I mean, certainly gabapentin works, it's also a great sleep medication, but GABA channels are what helps with pain relief, in general. So anything that increases GABA, either directly or indirectly, can help with headaches. So pregabalin, typically, I always suggest the lowest possible dose for the maximum benefit and the least side effects. So whatever is tolerable and whatever gets rid of the symptoms. I know there's a maximum dose, but if I get to 150, say 70, you start at 75 and you get to 150 and it's not working, I'm already thinking, do we have the wrong diagnosis? Do we have the wrong mechanism of action? Like, what we're doing, let's regroup. I don't keep pushing the meds to the max. I do stop midpoint, because at midpoint, if it's not working, I want to reassess before going up further.
Okay. So I know when I have a really bad headache, I get terrible um, musculoskeletal headaches at the back of my head, and I can't sleep when it hurts that bad. So um, if you're having trouble sleeping because of pain or something like that, can you take a sleep aid? Do you recommend maybe, I mean, it requires forethought, but trying to take an anti-inflammatory to maybe prevent the headache from getting worse? Basically, are sleep aids safe for patients with Chiari or central sleep apnea or brainstem issues? And I know we kind of touched on it, but maybe we could expand.
Yeah, sure. So I think that really it's important to figure out what is it that's causing the discomfort. So again, like I said, if it's a trigger point or some musculoskeletal, like specific musculoskeletal issue, is it a nerve irritation? Is it this muscle trigger point that's affected? Then those have to be treated. That'll give you more relief than taking medications. Now, if you were the other option is to try topicals. So you could try a topical, non-steroidal. There are also some combination topicals that you can get compounded. And it's very fascinating, the combinations, a little bit of gabapentin, a little bit of clonidine, a little bit of this, I mean, things you would never think of. But it's in a topical form, so it's local and not going to cause side effects when you take it, if you had to take them, if you had to take them orally. And certainly you cannot mix all of those medications and take them all at one time. It's much more effective to use it topically because there's so many of them. I think sleep aids are a risk no matter what, Chiari or no Chiari. And I think in the sleep clinic, we prescribe them the least because there is usually a cause for the sleep problem. If it's pain, we have to treat the pain. If it is insomnia, you treat the insomnia. So whatever the cause, and really finding out the cause, and that's the beauty of the evaluations, right? It is a little bit of an investigative road that you travel, like really trying to figure out what is and pinpointing the actual cause and treating that specifically is far more rewarding than just giving someone a medication. Because certainly we can give you a medication and make you sleep, but I would, depending on the level of the Chiari or the level of brainstem compression, we would definitely be very careful with sleep medications, because like I said, sleep medications, especially the benzodiazepine receptor agonists, they work on the same receptors as alcohol. So essentially they're just suppressing you're strengthening your sleep chemicals. So we want to be really, really careful. And sometimes maybe if it's falling asleep and not staying asleep, that's the problem. You could use a short term, like a short acting medication that will only last 4 hours, or some of the ones that last long in your system, and the ones that, especially the ones that leach into your muscles and stay in your muscles the next day, those are much more problematic because they're unpredictable. The effect on you is unpredictable.
Yeah. Kind of to that point, so I know you were talking about earlier that opioids and anything that sort of suppresses your brainstem activity, you have to watch. But as far as getting surgery, I guess you have to go under anesthesia. So
Yeah.
are there particular considerations for maybe patients that are having sleep apnea issues, stuff like that, for just, I guess, in recovery or going under? Like how does that get?
Absolutely. And that's why you have an anesthesiologist when you're there having surgery, who is monitoring your oxygen levels, your carbon dioxide levels, and making sure that your airway is open, and delivering oxygen to you while you're under. Post-operatively, according to the research that I found, because of the swelling in that area just immediately after surgery, yes, you're at higher risk for sleep apnea. So it definitely works. So a lot of times, right, there are surgery, I mean, never in neurosurgeries I haven't seen, but some surgeries, they'll send you home the same day, right? A lot of times people have tonsillectomies and they're sent home the same day. But in this condition, or in certainly some specific conditions, we will insist that you are monitored overnight to make sure that doesn't happen.
Perfect. So this is interesting. I'm not sure how to even broach this, but an individual had a smart meter put on their home, and the daughter's headaches seem to have gotten worse. So I don't know if there's some sort of electric environmental thing at play with headache. Because it seemed to have improved when she went away to the country, but I don't know if that's something about going from more of like a suburban or a city environment to country. What are the different environmental factors, I guess, that would impact headache?
Oh, I would look at the air quality. I've had people who had, for example, a flute changed in their furnace, and it caused increased carbon dioxide levels and increased headaches. That's a factor. Mold is a factor. So mold that causes sinus congestion. I mean, there are some parts of you, there are sinuses that are deep. There's one specifically, sphenoid sinus, which is much deeper in the brain. and that just causes unrelenting headaches. And so those are the two factors I would look at: is air quality, so anything that's causing sinus congestion, or including allergies, right? It could be allergies. I would look at all of those environmental factors. Humidity is a factor. Sometimes people need more humidification in their sleep environment because their nasal passages could be drying out in the winter time, especially. So yeah, I would say a number of environmental factors. Other things that get better when you go away into the country, I mean, noise, right? Noise levels, light, ambient light or light levels coming in through your windows, stress levels, all of these things can affect headaches too. So I would, yeah, really figure out what it is that's changed. But if it may not be the smart meter, but it certainly, I mean, could be the air quality. Yeah.
For sure. And this is a good question. I think any other last minute questions, we're going to try and squeeze them in, but this is a pretty good semi-last question. So are there sleep clinics specifically related to Chiari other than the one that you work at, or can any sleep clinic help Chiari patients? Is it advisable to go to a very specialized clinic? How does that work?
I would say it would be helpful because in a sleep clinic, a lot of sleep clinics are multidisciplinary, right? You have pulmonologists, you have neurologists, you have psychiatrists. I would say if you are going to a sleep clinic, it would be better for you to go to one that go to see the neurologist in the sleep clinic because they are more likely to understand what's going on with your Chiari malformation. Now, that being said, there could be a neurologist that doesn't understand. So I think choosing a provider that understands both is very, very helpful. And if you don't feel like you're getting that, you should change because your doctor should be able to get what you're saying.
Yeah. This is actually a good question that just came in. And I know because you work with Dr. Luciano that there's a lot of this that you see. So can intracranial hypotension, like low pressure, cause I guess disordered sleep in general, but specifically like hypersomnolence, so like you needing more sleep. This patient's saying that they experienced this after a leak actually that was difficult to heal.
It depends on where the leak is. So you can have leaks in your brain, right? So if you have leaks from your ears or your nostrils, typically that's from high pressures. And again, the CSF has to go somewhere, so it leaks out into your ears and through your nose because those are the most vulnerable parts of your brain where the bone is thin. Now, in those cases, typically it's high pressures and sleep apnea causing high pressures in some cases. So a lot of times, for example, people will have those repairs done without treating the sleep apnea, and their leaks happen again. Similar to why a Chiari happens because the high pressures are not treated. What we do at Hopkins is that we will monitor intercerebral pressures before and after surgery. We have a case tomorrow, for example, where we will measure pressures overnight just to figure out what the baseline is. And granted, when they have a leak, they may not have as high pressures because they have a leak. If you think about it like a water balloon, and you have a small leak, you patch it up, but the pressure in the water balloon is still high, it's going to open up again. So post-operatively, we really monitor very carefully for high pressures, and very often it's related to sleep apnea, and in those cases we want to treat it. Now, immediately post-operatively we can't treat because you can't use CPAP right after you've had nasal or brain surgery. So in those cases, typically we'll have the head end of the bed elevated. Sometimes just treating with oxygen overnight works as well. So that's one cause of a leak. Now, the other area that you can leak is in your spine, right? So when you have cerebrospinal fluid leaks in your spine, that could be also from high pressure. So we have these cases that we call high-low symptoms. So you have high pressure that's then causing the leak, that's then causing low pressure. So typically those patients have high pressures when they're lying down and when they're supine overnight. Therefore high intracerebral pressure, possibly sleep apnea related. And then when they stand up, they have low pressures
Mm.
negative pressures. So really, and even in those cases where they have spinal leaks, if you plug up the leaks but don't treat the high pressure, it's going to happen again. So really, it depends on where's the leak, what is causing the leak, and whether or not sleep apnea is involved at all. If you have a spinal leak, certainly you can have a brainstem or a cerebellotonsillar lag or ectasia. And I suppose in those cases, then it's the same mechanisms that happen in a Chiari, because that's essentially a Chiari would be at play, causing the sleep disorders.
Yeah. Okay. So I guess I want to just close with how people can get in touch with you. So first of all, do you see adults and pediatrics? Do you only see adults, only pediatrics?
Only adults.
Only adults. Okay. And then I guess if people want to get in touch with you and maybe get a sleep study or
So so I would say the best way to get in touch is through the Sleep Disorder Center at Hopkins. There is a phone number that I could, that you can call to be referred specifically, or you can have anything through the Cerebrospinal Fluid Disorder Center as well. So yeah, do you want me to just give you the number, or?
If you know it offhand, I could also look it up.
Yeah, okay, yeah. But 410-550-2412 is the Sleep Disorder Center. And then there's another number, 410-550-6487. Those are the two good numbers for the Sleep Disorder Center.
Perfect. Awesome. Thank you so much, Dr. Rao, and thank you everyone for joining us. This was awesome. And I could actually feel my circadian rhythms starting. So
oh, me too. 9:30 is my bedtime.
But thank you so much. This was great. Thank you.